PhD. In terms of health care in Georgia, which is precisely what our next speaker has been involved with. Kenneth Rethmeyer, who is a PhD and is Vice President of Policy, Research, and Data Service for the Hospital Association of Pennsylvania, has been involved in a coalition of employer and hospital effort to bring more value, a combination of cost and quality, to the residents of Pennsylvania. Dr. Rethmeyer, before joining the Hospital Association of Pennsylvania, served 21 years on active duty as a healthcare administrator for the United States Navy. He received his bachelor's degree in public health from UCLA and his master's from the University of North Carolina. Dr. Rethmeyer has served as a faculty member of the American Hospital Association Joint Commission on Accreditation. He has had a considerable amount of publications involving research articles on patient perception. He's held numerous university faculty appointments and has worked as a consulting specialist in organizational design. So we're pleased to welcome Dr. Rethmeyer and his presentation on private sector initiatives.
Thank you, Ed, and thank you very much for allowing me to be a part of this exciting project that you have ongoing in Georgia. I bring you greetings from the Keystone State, the state of Pennsylvania, where today Hillary Rodham Clinton is participating in the first of a series of efforts in trying to understand what healthcare reform is going to mean for all of us. It's a great opportunity, I think, for our members. My boss, John Russell, is going to be there, along with representatives from the Medical Society. Obviously, Governor Casey's office will be there, and Harris Wofford is sponsoring that effort. Harris Wofford, you may know, is the junior senator from the state of Pennsylvania. He was elected running against Dick Thornburgh, who was 40 points ahead of him at the outset of the campaign. Harris Wofford ran on a campaign of health care reform, which he really didn't understand what he meant, but he won. And he's making it count for real across our state, as well as meeting other members of the Senate. Just to give you a bit of a background, Pennsylvania has 228 acute care hospitals, about 18% had negative operating margins. Coincidentally, there were about 20% turnover in our CEOs. We commonly joke about the fact that you can always tell where the CEO's office is in the hospital because it's the one with the automatic revolving doors. The good news is for his or her staff, it provides instant access to the CEO, the strategic apex of our institutions. The bad news is the president of the medical staff organization and the chairman of the board both have automatic opening devices and can turn it on at any time. So, in effect, in our environment, we have had a series of opportunities to deal with private sector initiatives over the past 8 to 10 years. If you look back at the mid-'80s, and this is the time when business, and I'll be referring to some material that's handout number 4 for you, business was beginning to monitor very closely what was happening to healthcare expenditures, not only in terms of national experience, but also what was happening to their bottom line. And I'm going to show a graphic for you. They monitored it and found that the cost was becoming ridiculous, eating away at that bottom line. From our perspective as providers, and this is national data, our payer mix across the United States looks something like this. In Pennsylvania, about 50% of our payer mix comes from Medicare and Medicaid. Medicare about 37%, Medicaid, or what we call medical assistance because it extends beyond Title 19, represents about 13%. Both of those payers pay below cost, and as a consequence, it creates a significant problem for us. We were one of the states, by the way, who participated in the voluntary pooling exercise over the last couple of years. That has expired. Our state is now facing about a $350 million shortfall in the Medicaid budget. Yesterday, Governor Casey unveiled his budget, which left us with significant cuts in the program. From our perspective as providers, we see this as two things. First, it's a provider tax indirectly imposed upon us because it increases our uncompensated care. And secondly, it will become a hidden corporate tax because guess who's going to pay the difference? It's going to be passed on through the cost shift mechanism to the private payers. By the way, Blue Cross dominates our market at about 70% penetration, and therefore the number of commercial payers is very, very small. It's that kind of environment that we have been experiencing over time, and this graphic shows you what we mean by the percentage of healthcare spending against business. In 1965, it represented about 14% of the bottom line. It's now about 94%. Rapid increases. You can't live with that if you're in business. Likewise, from our perspective as providers, taking a counterpoint approach, if you look at the impact of cost shifting, the red representing everything that's below cost in terms of reimbursement. By the way, auto insurance and workers' comp will now be paid at Medicare rates, so you can imagine what that will do to us. Somebody has to pay the difference, otherwise you go out of business. With 18 to 20% of our hospitals operating in the red, it makes it very difficult. Furthermore, as business looks at their own employment experience and the cost of health care for families, these figures illustrate rather candidly the kinds of escalation that we're all facing. So that in effect, if you think about it, hospitals are both employers and providers. Hospitals also have employees and provide community service. And all of these competing demands led our organization and business to understand that this kind of impact would result in a dissipation of the positive relationships that our organizations have had with business and their communities, that it could dissipate to an acrimonious relationship and open warfare would take over. During the mid-1980s, a gentleman by the name of Walter McClure, out of the Center for Policy Studies in Minneapolis, brought to our state a concept that he referred to as buy right. We've now transformed that to what we call private sector initiatives. But in essence, his model said that consumers make better decisions about the purchasing of health care when they understand the complexities of the system, the cost of the care, and the outcomes that they can anticipate given the kinds of levels of intensity and modalities in which that care is provided. His idea was that in order to foster the kinds of relationships that ought to be occurring in the partnership between the principal purchasers of health care, that is, companies, with the principal providers of what is now called the payer food chain of health care, hospitals, that by bringing them together in a forum in which they could share health care information, both quality and cost, each learns more about the expectations of the other, and in doing so, create a bonding, if you will, and fostering of a better informed public about the purchase of health care. It was that kind of concept that in 1987, the Hospital Association of Pennsylvania provided seed money to establish private sector initiatives, or at that time, by-right councils across the state, or emerged in virtually the four corners of our state. The Lehigh Valley, Philadelphia, Pittsburgh, and in the Northwest in Erie. 3 of those councils remain active. Erie has been dormant, although the business community is now spurning us to come back to talk about the project that I will describe for you shortly. Philadelphia is active, but not doing the kinds of things that we're doing in Pittsburgh. Lehigh Valley has left our primary support and works on their own and very actively involved in community needs assessment. So they have their own perspective that they're pursuing. Very innovative efforts. The projects were originally designed to be 3-year demonstration projects. The idea during the first year was to provide an opportunity for both providers and purchasers to break down some of the barriers that have built over time. The second year, to take the information that they collected, to provide it in a usable format, but without designating which hospital was which, so the guilty could remain nameless. And in the third year, to expose the names so that the hospitals and the providers have had an opportunity to clean the data. And what I mean by that is this. We were using a combination of both UB82 data and severity indexing scores generated through METIS groups, the Medicaid system that is mandated for all of our hospitals in excess of 100 beds across the state. We're one of the fortunate states that has a healthcare cost containment council. We most recently, meaning the state, published a report on coronary artery bypass procedures. For you physicians in the audience, if you performed over 30 cases during the period of 1990 to 1991, your name would be in the book. It would show how many cases you performed, the number of deaths you had, whether that death rate exceeded an expected mortality rate or not, so forth and so on. It did not, interestingly enough, did not result in any significant backlash or, to date, significant change in healthcare delivery or demand patterns. We're still waiting to see whether, in fact, those kinds of changes emerge. And I think it probably suggests that in our state, we're beginning to learn about the importance of having healthcare data in the public forum. One of the standing committees for which I'm responsible for in our association is the Committee on Healthcare Data. At our most recent meeting last week, the committee members took the bold step to say, we will establish a policy that we will publish hospital-specific information from the association. Now, that may sound strange to you, but in our state, the historical context has been hospitals are very protective of both clinical and financial information. Indeed, I have a great deal of difficulty in my normal job getting them to provide us the data we need to serve in the advocacy role that we play for them. So in effect, the BioRite project was a microcosm of the kinds of networks that we hope to develop over time and an opportunity to break down the barriers that we've seen. And the underlying issues that I identified on this slide are paramount to the success of those programs. The basic model that they operated under was the following. Now, you might look at this, and those of you who have been involved in health services management over time, particularly the nurses, will recognize that you could actually turn this around and deal with this as how do patients respond to symptoms, which in this case are the data. In the BioRite councils, hospitals provide us duplicate copies of the tapes. They submit to the Cost Containment Council. We manage the data and put it in the format that they want to see. So the interaction then, up until this about a year and a half ago, was for the provider and the purchasers to define the format and the content of information that they wanted to see and use in the process. If you follow the model, as was described by the folks from OER, data transformed through interpretation and integration becomes information, which then is transformed, in our case, to a willingness to act. For purchasers of healthcare, notably the kinds of folks that we have involved in the Pittsburgh project, and I'll reel them off for you: USX, Alcoa, PPG, PNC, Mellon Bank. We've invited US Air, Westinghouse, Equitable Gas, and most recently, we added to our membership Blue Cross of Western Pennsylvania. That was a major change in the culture of that council, and I think if you think about it, it illustrates some of the breakdown of the barriers that have emerged over time. We really are moving from the competitive environment to a more collaborative approach. Not without speed bumps along the way, but it is occurring. Within the last 3 to 5 years, the emergence of the projects resulted in the kinds of actions where Alcoa, through Dick Wardrop, who was the benefits manager at the time, issued an RFP in the Pittsburgh area for the contracted services for healthcare for its employees. The Alpha Network won. They are members of the Buy Right Council. Alcoa and Jim Rashad, who you may have heard about or seen, he's been in the press recently, would tell you that they saved about $400,000 a year as a result of the process, and would say that the value of the Buy Right Council, private sector initiatives, has been beneficial to his organization. About a year and a half ago, we held a leadership conference at HAP, the Hospital Association of Pennsylvania, to talk about where the councils were, because we kept getting mixed messages. And our role, by the way, is to serve as facilitators, to participate in their effort, to help them along, but we don't direct their activities, at least not overtly. We do it indirectly. Well, the conference basically resulted in the following kinds of conclusions. We've been very successful. We've broken down a lot of barriers. We're talking to one another. We're dealing with issues that we think we both have common ground to work around, but we're at a plateau and we're sort of stumbling with where we want to go. Well, I have to tell you, to digress for a second, my mother and father had 2 children. One was a fast learner and one was a slow learner. Now, we both did our undergraduate work at UCLA, albeit 4 years apart. By the way, my basketball record is better than my sister's. Unfortunately, she graduated Phi Beta Kappa Summa Cum Laude, so you can tell which side of the spectrum I was on from the intellectual case. I sat down and had an opportunity to talk to the folks at Hershey Foods, who are really doing a lot in managed care, and I guarantee you, 1 January 1994, you're going to see some major changes in the way they deal with the managed care marketplace. It's got all of our hospitals, 5 of which in our city, Health America, U.S. Healthcare, Keystone, and all HMOs in what I will refer to as a super STIP. An intense level of activity to demonstrate performance. In any event, Alcoa, Hershey Foods, Armstrong Flooring in Lancaster County, Pennsylvania, all were involved with CQI, and they all kept saying the same thing. We'll deal with any hospital, any provider, physician, rehab, psych, doesn't matter, if they're involved with CQI. Because we do CQI as industry, we see value in our systems, and we think it has application in your environment, and we serve on your boards. Indeed, the chairman of the Lancaster General Hospital Board was one of the senior management folks from Armstrong, Corning, influenced Sayre, Pennsylvania, and Robert Packard Hospital, and the list goes on. It sort of dawned on me, the slow learner, that maybe what we ought to be doing in this project in private sector initiatives is linking together the goals and philosophy of private sector initiatives with the principles and tools of CQI. Somehow focusing on clinical pathways of care, and we'll describe that shortly. The principles really meant that we wanted to try to transform the focus of our attention away from competition, moving to collaboration, to deal with the kinds of existing customer-supplier relationships that have already been established through some kind of network analysis. Where are the strong linkages between the U.S. sexes and their principal providers? Why can't we build on those? Why do we have to always focus on trying to redirect the demand for care? Redirecting the demand for care, in our perspective, was counterproductive from what private sector initiatives illustrated. Employers were focusing on cost, providers on market share, and those tended to become competing. So we were trying to redirect their attention. We wanted to use claims data to uncover what was happening to individuals in companies in our institutions. Because if you look at, from our perspective, just hospital data, what we found was it's biased by the extent of Medicare, by the extent of medical assistance or Medicaid, and so forth and so on. So we convinced the group that what we really wanted to do is to put in the pot all the claims data from all the participants. Initially beginning with just the companies, the hospital CEOs said, wait a minute, this has value for us as well. We'll throw our data in the pot. So we spent about a year formatting, collecting, analyzing claims data. We wanted to focus on attention to local needs. And by that I mean defining clinical pathways by specific DRGs. Let's chunk down this complex system that's very difficult to control into workable units that people can understand and deal with. So we wanted to focus on specific DRGs. We also wanted to expand our concept of clinical pathway analysis. Some people call them clinical paths, clinical practice guidelines, what have you, to broader than just the in-hospital perspective. Let's talk about what happens before you arrive at the hospital. Let's talk about your relative risk. Let's talk about the experience you've had with the healthcare system in the past. And how does that influence how you behave as a patient? And on the outcome or post-hospital setting, how is that baton passed from the hospital to the follow-up care? For those of you who are quality assurance or quality management directors, you may realize that the Joint Commission, not to sound like the polyester of the joint, over the period of 1992 to 94 is now calling for the patient and family education chapter that you must document on the discharge documents what follow-up care and who's going to provide it, and you must notify that agency as well. So there's a greater attention to this, and we want to expand our focus. And I'm aware of a lot of innovative work that's going on across the United States. A very good friend of mine by the name of Jack Ford, who is a board-certified forensic pathologist who believes that CPR is a conflict of interest, has been doing a lot of work in clinical pathways. He took Anne Arundel Medical Center's clinical pathway for total hips from 12.2 days average length of stay to about 7.5 inside of 18 months. It went from a loser in a rate-regulated environment to a winner. And at most recent notice, this past June, it was around 6.8 days, average length of stay. And they did that by bringing together interdisciplinary groups. So our focus is wanted to be more in that direction. We wanted to link CQI and clinical pathway analysis because we saw a match with those two concepts and to apply it in an inter-organizational perspective. That is, let's get employees involved. If they participate in the process, as has been described just a few minutes ago, there's a buy-in. Employees, because they don't traditionally pay for health care in the majority, don't necessarily understand the complexities that they go through, although they experience it. So they're also a valuable resource, and they're also a group that we need to co-opt, with pardon that expression. That was part of the process. And lastly, we wanted to deal with results that talked about financial, customer satisfaction, the diffusion of technology and innovation, and better ways of doing things, like in the outpatient service or in other modalities of care, as well as eliminating the unnecessary variation in the clinical pathways that we examined. So this was the concept that was rolled out on the table in December of 1991 at our Bi-Right Council meeting in Pittsburgh. They bought the concept enthusiastically, and we've been working with them ever since. This slide illustrates for you the common issues that we're talking about in regard to the project. Dealing with control of variation, both common and unique causes, and looking at the differences in impact of relative risk that patients bring to the system and rates of demand for services have on the system. And I'll describe that more shortly. If you have not seen it, there's an excellent article by Donald Berwick, by the way, in Medical Care, December 1991, on controlling variation. And I think it's written in such a way that anybody can understand it. It's a non-statistical, very good illustration, and I highly recommend that to you. This is the model, then, that we've been working with. Relatively complex, a lot of involvement by our participants, and the focus of attention, although it's been primarily on these health services pathways, extends to risk assessment and health services utilization. Why is that important? It's important because our patients come to us with two pieces of baggage. Risk in terms of their genetic makeup, their workplace environment, their occupation, their lifestyle, and those all influence what happens to them once they get into the system. It may also influence how often they have to use the system. And it may be an opportunity that we can work with companies to try to minimize, to reduce. Okay? That was one of the issues. Secondly, we wanted to take a look at health services utilization. And by that I mean, what are the relative rates of admission for the same DRG across companies, or in some companies, across the various plants or locations that they operate. You may recall that a few years ago, GE did some rather interesting work involving small area variation analysis, using and calculating company rates of admission. I have to tell you that both the risk and the health services utilization components of our model, we're still having to break through a lot of barriers to work on. On health services utilization, when we go to the companies and we ask them, we need to identify the denominator of the equation, how many insureds are there so that we can calculate the rates. They can tell us the number of insureds, but they don't know how big that population really is. On risk, the barrier there is talking to companies and sensitizing them to the issue of a dollar spent on health promotion can result in other beneficial effects. Those may be long-term. And when we think about, and I think this was addressed earlier, the short-term mentality that we all come to the table with, those are difficult issues to deal with. Very briefly, the steps that we developed to walk through the model are defined on this slide. Basically 6 steps. Ideally, this would be the case. In our situation, we had a series of folks who had been working together for a number of years. They had a good knowledge of the top 25 DRGs. They had looked at average length of stay, adjusted by severity scores. They had looked at charges. They had looked at a number of other issues in terms of mortality and morbidity, albeit the morbidity data is less reliable in the old medical system. So we had some experience, and what they decided to do was to focus their attention on 11 DRGs, some clustered, and some ICD-9 groups. Now I have to tell you, DRG 430 was not our choice, but it was USC's choice. In fact, they demanded it be put on the list because from their perspective, that is their #1 problem. Interestingly enough, as you look down at the ICD-9 codes that encompasses It's a broad range, and therefore must be taken into account that not everybody ends up psychotic who works for USX. I would not want to do that impression. In looking and analyzing utilization patterns, as I described, we pulled together claims data. We attempted to take a look at small area variation data, which we have in-house, statewide. And I'm now purchasing the data, a complete data set from Codman, who is the contractor for our Cost Containment Council. We'll be able to go right down to the health market area across the state. That includes zip code. And to compare admission rates across the organizations, as well as in comparison to their health market areas and the state, see whether there are significant differences. If you think about risk analysis, if you're in a high-risk environment, you would expect your rates to be higher for certain DRGs. They ought to be fairly closely correlated. If they're not, that suggests something. Or if your risk is low and your rates are high, that may suggest something, without drawing any specific conclusions. So we pulled together, quite simply, through a number of carriers, which involved all the indemnity programs. I recently spoke to Help America, which is one of our major HMOs in the state, probably the fastest growing. Just recently purchased Health Pass, which covers all of Penn State. We involved all the indemnity programs. It resulted in about 1,500 cases for the 11 DRGs, and I'll describe that for you. In any event, what we've done since then is to narrow down the DRGs to two. The focus of attention right now is on two DRGs, 243 and 215. 243 being lower back and 215 back and neck procedures. Quite simply, the distillation process that we went through with the purchasers was, these have implications for you because they're worker comp related. Worker comp, the insurance department in the state recommended a 52% increase in worker comp insurance rates this last year. 52%. So that got a lot of people's attention. They negotiated down to 26%. Still something. What we were also attempting to do, as I mentioned earlier, through some form of network analysis, is to begin to help companies understand that they have significant customer-supplier relationships with some providers. And although this is a hypothetical illustration developed long before we ever looked at the data, the results of our analysis substantiate that, in fact, providers are linked to specific companies. And it's important because that's how we wanted to craft the quality improvement teams that we were going to develop. Now let me just give you a sense of some of the aggregate information that we compiled as a result of our analysis. The first diagram, interestingly enough, looks somewhat like a Pareto chart. What was not noted this morning is that Pareto was an Italian economist. Some people would say that that's an oxymoron. But in fact, he did theorize that about 80% of the wealth is spread across 20% of the population. And that forms the basis around this kind of analysis. Interestingly enough, as you look at these DRGs, and we'll walk through it very quickly, about 75% of the total by volume are concentrated in 4 of the 11 DRGs. The most frequently noted 373, which is normal vaginal delivery, 183, which is esophagitis, 243, which is low back, and 430 is psychosis. Followed rapidly by those involving some of the pneumonias. The AMIs were at the bottom of the list, interestingly enough. We only had one death out of the 1,500 cases across the 11 DRGs. One of the things that we've not done, we're still working on, is trying to link the outpatient data. We're trying to co-opt the Blue Shield of Western Pennsylvania to help participate with us so that we can link the outpatient information as well. If we look at average length of stay and variation around those average length of stay, you see these kinds of things. Well, it's not atypical that the average length of stay for psychosis is long, 16 days plus. the standard deviation is 10. As you go down the list and you look at 373, a much tighter fit. One would expect that. Now, to give you some sense of where we fit with our neighbor to the south of Maryland, our average length of stay in this case was 2.7 days. Maryland just recently implemented a requirement in their regulations that they will reimburse 1 day length of stay on normal vaginal delivery, 373. Anne Arundel Medical Center, because it's been involved in clinical pathway analysis, had already achieved a 1 day length of stay 12 months before the regulations ever went into effect. So there is benefit. When we look at average charge and payment, we see this kind, the charge being in red, payment in blue. 373, very tight. 430, interestingly enough, why do they match? That's when your benefits run out. Fairly typical. Large difference between charge and payment in the AMIs, as well as in those areas that are involved in pneumonia. Pneumonia for our state has been one of those areas that's been studied a great deal. The Alpha Network has been using clinical practice guidelines for some time. In fact, they were written up in the literature as a consequence. When you look at total payments, you see this kind of thing. My interpretation of this graphic is there's a strong connection between 430 psychoses and the payments for 373 normal vaginal delivery. My conclusion is we've got to be crazy to have children. Short digression. I have 2 children. My daughter is a senior at Virginia Tech. Jack Ward, who she knows real well, has nicknamed her Adelina. Adelina was Attila the Hun's sister. And my son used to look like he had a chipmunk sitting on the top of his head with his hairdo. He's sort of the artistic one. But between those two, I've come up with this idea, this philosophy, that at about age 13, children develop an adolescent's form of Alzheimer's disease. You know, you see TGA, transient global amnesia. They forget everything their parents taught them. They develop episodes of oppositional disorder. And at last count, it lasts at least 8 years. See, my daughter just turned 21 in October, so I'm still waiting for her to emerge out of that. Our purpose of looking at this information was to draw attention to the companies and the providers that if you can follow the jargon of the Joint Commission, there are high volume, there are high risk, and problem-prone DRGs. There are high volume DRGs like psychoses and 373 normal vaginal delivery. There are some high risk or high average cost, and there are problem prone that are high total cost. We wanted them to think about the data before they made their selections. They centered in on 243 and 215, which are the work of conflict-related issues. Moving along rapidly, as I mentioned, we have not been able to deal yet with the risk assessment. We're actually going to be going out looking for some foundation money to try to help support that process. By the way, the process in our organization is that each of the members of the council, there are 11 hospitals in Pittsburgh, as well as about 9 companies, each participate on a fair share basis. They ante up at the beginning of every year, and then they pay for whatever data analysis or interpretation or facilitation they receive as a consequence of our work. The results of the risk and utilization analysis eventually will bring us to the point where we will be able to hopefully target populations within the companies around which we want to pay closer attention, because we think there's value in focusing attention on their clinical pathways for their high volume demand of care. This slide merely illustrates that looking at health services pathways, our intent was to allow them to go through a long process of coming to consensus on a small set of DRGs to focus attention. In fact, that happened rather rapidly, and we've been in the process of forming our quality improvement teams between businesses and providers to set about this process of studying the clinical pathways. The benchmarking approach that we're going to use, by the way, is to begin by soliciting from other organizations those clinical pathways that we know already exist, so that we don't totally recreate the wheel. To establish a benchmark, if you will, the ideal clinical pathway, and then to solicit through the companies and some of the hospitals to bring in employees and patients who participated in the clinical pathways over the past couple of years. Feed them a nice lunch and then interview them for a couple of hours to have them describe the clinical pathway they went through as they moved through the system. What we hope it will do is sensitize our QITs, our teams, to the idea that there's an ideal and there's reality, and the gap in between is the opportunity for improvement. And then we'll apply CQI, the data collection, interpretation, and all the tools to bring the whole organization through that process to show value on the outcome side. The framework that we're going to be trying to use in analyzing the clinical pathway looks something like this. Going back to the original model, if you think in terms of primary, secondary, and tertiary prevention, primary prevention says we know that there are certain things that create greater risk: smoking, lifestyle, workplace, kinds of occupation, that may be modified, that will reduce the level of intensity of the health pathway that you pursue, and it may modify how you use the services as well. Secondary prevention says there are some things that we know that have high risk. Low birth weight babies. We run about 7.2% across the state. Philadelphia is much higher, obviously. The large urban areas, some counties, the rural counties, have higher rates. We know that that's associated with race and socioeconomic status, not easily modified. But we can prevent admissions to neonatal intensive care units by early detection and treatment. Get them into those prenatal programs. We have a lot of blue-collar employees in our state associated with some of the big companies we're dealing with. We might have populations at risk. We can't affect the risk assessment, but we can get them into programs. If you avoid neonatal intensive care units, you will avoid the kinds of other problems that are long-term. Low birth weight babies usually have chronic neurological problems. And that means healthcare dollars expended for the rest of their lives. We might be able to affect that. We have one hospital in the western part of our state that I'm going to follow up with who is dealing with that issue. They've dealt with 600 women in their community, their health service area, and they are focusing attention and they are avoiding unnecessary costs. Well, obviously, if you've been smoking for 35 or 40 years, drinking heavily, working in an environment where you have potential for low back problems, you're going to have active disease. So what you're really trying to do in terms of tertiary prevention is reducing disability, impairment, and suffering. Our idea is that if we can map out this clinical pathway and we can focus a broader perspective outside of the hospital environment, we might be able to really make a difference in the totality of care. It's a grand experiment, and it is truly an experiment, and the people who are involved are energetic, they're interested, and the level of effort coming from the companies is changing. We're sort of going up in the food chain of the organizational chart of the companies. We now have the medical directors from USX, Alcoa, PPG, and one other company that escapes me involved. We've got representatives from the Pennsylvania Medical Society, from the medical staff organizations, so we have clear clinical involvement in the process, and these are the physicians that are really the change agents in their own organizations. This slide is merely a conceptual diagram to give you a sense of the kinds of focus that the clinical pathway may involve. This would be step one in our process. Let's use the fishbone to map out the kinds of nodes for which there may be unfortunate and significant unnecessary variation. Then we will systematically attack each of those as we move through our process. The end result truly is to focus on performance. What's the outcome? Because, quite frankly, benefits managers have little or no security in their own employment, so we want to help them as well. And we want to help our own providers. One of the things that I'll disavow ever having said, even though I know you're taking it, we found some significant patterns when we looked at hospital average length of stay and charges when you look at patterns for employers and their employees in our hospitals, and hospital employees as patients in our hospital. I'll leave you to guess which one had the lower length of stay and the lower charges, but as yet, the light bulbs haven't all clicked with the business side of our communities yet, and once they start looking at closer at the data, they will see some of these patterns in it. That is not to say that I'm trying to be pejorative, but rather we're focusing attention, and there truly has been a collaborative effort here. Some of the accomplishments that we think that we've achieved to date has been that we've involved both company and hospital data. It's claims information. We have Blue Cross, as I mentioned, as a member now. We believe that there is more collaboration than competition, both between our hospitals and between the companies and the hospitals. The environment of the meetings is significantly different than it was 3 years ago. Businesses are learning firsthand how to really understand what happens in the system. The benefit for our providers is they talk about the complexity. Now some of the companies are beginning to understand what that complexity means and how difficult it is to control. I have described on some occasions the hospital is like a gigantic pinball machine. We launch patients through admitting or the emergency room, and they bounce up to the top of the organization, back and forth, admitting, OR, laboratory, X-ray, back and forth. Some people in business would argue that the CFOs and the presidents of the medical staff organization have their hands on the paddles and keep bouncing those patients back up into the system. That's the abnormal or unique variation. No two patients follow the same pattern. We saw significant differences in average length of stay. We saw significant differences in charges and payment. We're beginning to put together a broad spectrum of understanding about the entire process. We believe that there is significant value in the linkage between business and provider using CQI. In fact, we have gone to the purchasers and asked them to provide us with the trainers for CQI, the tools. Mellon Bank's going to do that. We're going to use the Alpha Network and the physicians in that community to describe the clinical pathways approach that they've used, and that's how we'll educate. So right now we have 4 basic committees: an education committee, a clinical pathway committee, which will do the flow charting and that sort of thing, and developing the clinical benchmark. We have a committee taking a look at risk, and we have a committee taking a look at the outpatient data and how we can bring that linkage in. The implications for the agenda of our new directions in this project, we believe, focus on the following kinds of efforts. We're trying to get away from short-term symptomatic issues to systemic long-term objectives. Trying to make a paradigm shift between the traditional model of management to a longer perspective. We believe, as a bottom line, that by focusing on quality and managing quality, in effect, you are managing costs. And that everybody can walk away winning. That's sort of the vision that we have. That's the vision that's been promoted in Pittsburgh. And that's the vision that I'm trying to leave with you today. As we talk about visioning, I think this quote from Warren Benison and Burt Manis is probably the best. It really is a function of leadership. It really needs to be clearly articulated. It needs to be simple. It needs to be easily understood. And most importantly, it needs to be clearly desirable and energizing. When I talk about visioning, the example that I give usually comes from my own experience as an undergraduate student at UCLA. One summer I had the opportunity to work at Disneyland. In fact, the fellow that got me a job working the Jungle Cruise. You may remember. How many of you have ever taken your families or your spouses to Disneyland or Disney World? It's okay, you can answer. I don't ask that question to you, though. That's not the right question. Well, you remember the beginning, right? Welcome aboard, unwary travelers, to the Congo Maiden. My name is Ken, and I'll be your skipper and guide down the rivers of adventure. We're going to pull away from the dock, but before we get too far away, I want you to turn around, wave goodbye to your friends and family. It may be the last time you see them. As we leave the last outpost of civilization, we enter onto the mouth of the irritable body River of Burma, where rare plant life and lush vegetation grow in abundance. And it goes on for about 12 and a half more minutes. I know, you're asking yourself, how could a man my age remember that spiel so many years? I'll guarantee you, when you say that spiel 25 to 35 times a day, 7 days a week, you're going to learn the spiel. My point is that Disney, beyond anybody else, knew how to take a vision and turn the costuming, the props, the on-stage, off-stage mentality makes the difference. Just like you all. Whether you work for USX, or you work for the Georgia Hospital Association, or OBI, or Hospital X and Y. The minute you put the badge on, you represent the organization you are. And you live the vision. And the vision that you have in the project that you're working is not only noble, it's clearly desirable, and from what I've seen today, certainly energizing. It's energized me. I'm going to go back with a lot more than I brought down to you, and I want to thank you for your time. It's been most enjoyable. Best of luck.
Let's take a minute or two. Are there any questions of Tim?
Yes, sir.
What sources was that from? Was that all payers, or was that commercial insurance?
Commercial insurance, we had Blue Cross, Prudential, and Travelers, who are the major companies in that area. Yes, sir.
Toward the end of the presentation, you mentioned the State Medical Society. You also mentioned, I think, in one of your committees. To what degree were physician groups involved in the planning and the execution, and also parenthetically relationship with the Pennsylvania program?
Oh, okay, that's an interesting relationship. The question had to do with the involvement of physicians in the project. The chairman of the data committee of the Bio-Rad Council is Dr. Don Fedorov, who is an internist. He is also president and CEO of the Alpha Network, which is the physician-based system. He was integral to the process. Dr. John Harper, who is out of Forbes Healthcare System in Pittsburgh, there. Dr. Leon Black from USX has been involved. We now have the medical director from Alcoa.
How about the State Medical Society itself?
The State Medical Society and the Hospital Association entered into a joint agreement of support for the Bio-Rad projects about 2.5 years ago. Joyce Van Wagner, who is the hospital relations individual director for PMS, has been working with us. We really haven't had to worry about it because Allegheny Medical Society, which I failed to mention, is also a member of the Bio-Rad Council. So we have had, I think, some pretty good support out of the medical community. We're going to expand these teams, by the way, to try to bring in the physical therapists, to bring in the nursing staff, to bring in the lab people, to bring in admitted, who really are integral to the entire clinical pathway. Is it going to work? It remains to be seen. Depends on the level of effort. Right now, there's a lot of energy there. But that group of people that are participating, it has value. As long as that candle is lit, we're going to continue to feed it. Other questions?
Thank Thank you, Ken, very much. I don't think there's any question about the quality of the presentation. There is a question about the utilization management involving pre-admission review and certification, concurrent utilization review, hospital bill audits, and numerous other areas. Nancy, we're delighted to have you, and we're looking forward to your presentation.